All right, so as Jimmy mentioned, I'm going to be talking about high value care and a very big data, sort of large scale idea, and the very small scale everyday experience of a patient and clinician in the room together. Let me go through the required slides here real quickly. So the questions we're going to be considering today are these: what is high value or value-based care, and why is everybody talking about it? Where does quality fit in? How is it measured? How are payers trying to incentivize high value care, and how is that working? How did we define quality before we were focused on value? Who decides what constitutes quality, and does the patient have a vote? What is personalized care or person-centered care? Why is everybody talking about that? What's required to provide personalized or person-centered care? What's the Hopkins experience in personalized care, and what are our opportunities? And finally, address the question, how does person-centered or personalized care square with this big idea of high-value care? So the notion of high value or value-based care is everywhere. You'll Google it, you'll see lots of hits, lots of images, lots of content. And there are a couple of reasons for this. This is not a news story, but we spend a lot on healthcare in the United States in particular. This shows average spending on health on a per capita basis. And you'll see back in 1980, all the developed countries are sort of grouped together there. But over time, the costs in the US have really taken off and far outstripped those in comparable developed countries. The cost per capita was about $8,000 in 2010. It's closer to $11,000 now. And against that, you look at what is arguably a measure of the quality of healthcare in the US. This is healthy life expectancy at age 60, which is life expectancy adjusted for time spent in poor health because of disease or injury. And you'll see that in the US, we don't stand out as a high performer here. We're way down the list behind the UK, New Zealand, Canada, Spain, Japan, not a particularly distinguished record by this measure anyway. And it's really this kind of observation that led to this kind of stance. And this is a statement by Sylvia Burwell, who at the time was the head of HHS, who wrote that we needed to look at how we're doing things. We need to improve the quality of care across the board, but we also need to reduce the growth of healthcare costs. And a strategy for doing that involves tying payment to quality or value, and doing so increasingly in the Medicare program over time. And what that means is moving away from payment for number of services or volume of services, and more toward tying payment to indicators of quality. So moving away from quantity to quality as grounds for payment, away from volume to value. And terms like value-based reimbursement began to be discussed. And where does quality fit into this whole business here? Where does quality fit into the value equation here? And how is it measured? Well, in these terms, quality is seen as a term in the value equation. Value is the quality of care divided by the cost of achieving it. And if you're going to try to implement value-based reimbursement, and you're a payer, you need to come up with a way of measuring quality. What are the quality measures going to be? And one thing you can do is you can look at undesirable outcomes and select measures that are tied to undesirable outcomes, things like in-hospital mortality and morbidity, readmissions, that kind of thing. Or you can create new measures, which is a complicated process involving multiple stakeholders. And here's a look at who some of these stakeholders are and what the steps are. The researchers are involved in evidence development. Then a number of entities get involved in developing guidelines, which evaluate the extent to which practitioners are following the evidence. And then measure development, which is a very complicated process involving CMS, the AMA, all kinds of entities and organizations that develop the measures. And then there's a measure endorsement process. This is designed to provide assurance that the performance measures are evidence-based and methodologically sound. And this is where an entity called the National Quality Forum comes into the picture. We'll be talking more about them later. And then there are the measure implementers, those who use the measures, the purchasers like Medicare or other payers and federal and state entities and the like. And what these kinds of quality measure efforts yield are measures like this. These are what I'm going to be showing over the next couple of slides are measures that are endorsed by the National Quality Forum in the mental health and behavioral health area. These include process measures such as follow-up after emergency room visit for alcohol or other drug use and dependence, diabetes screening for people with schizophrenia, metabolic monitoring for children and adolescents on antipsychotics, those kinds of things. And then some outcome measures, things like PHQ after 6 months, depression response and remission after 6 months of treatment, 30-day all-cause unplanned readmissions following psychiatric hospitalization. Those are some examples of outcome measures that have NQF endorsement. And there are lots of others in other specialties. So the payers need to come up with quality measures, and then providers need to figure out how to respond to them in order to earn value-based reimbursement. And this has multiple components. For clinicians need to be engaged in meeting the measure requirements and providing supportive documentation. And there also needs to be an administrative infrastructure to support measurement. And we'll talk more about the impact of all this later. Now, so what are some programs by which payers are trying to incentivize high-value care, and how is it working? So this slide here shows some programs, value-based programs, pay-for-performance kinds of programs in the Medicare program. And this top line here in the table shows the enabling legislation that gave rise to these. Probably the most recognizable enabling legislation here is the Affordable Care Act, which gave rise to the hospital value-based purchasing system. I'll talk just very briefly about this. And then another one that you might recognize is MACRA, the Medicare Access and CHIPS Reauthorization Act, which gave rise to the merit-based incentive payment system and the alternative payment model initiatives. So quickly, what is this hospital value-based purchasing program? This was established, as I said, by the Affordable Care Act, implemented in 2012. And the notion here was to withhold 2% of reimbursement to hospitals pending the measurement of certain outcomes. And those included things like mortality, hospital-acquired infections, safety, patient experience, a variety of things. And then the idea is that this would create a pool of dollars that could be drawn on to reward the hospitals with the best outcomes. So you could earn incentive payments by scoring well on those measures of quality, arguably. So that was the model there. Another national initiative in the sort of value-based care arenas authorized by MACRA was a merit-based incentive payment system. And in this system, Medicare payments to physicians and others are tied to performance on a variety of measures, some of which are quality measures, but there are also measures of cost and the use of electronic records and participation in performance improvement activities. And the idea here is that if physicians and other providers hit performance targets, then their Medicare reimbursement, the increases to the Medicare fees or to the allowables from Medicare increase over subsequent years. There's an advantage in terms of those updates if you score well on these measures. And then there's the alternative payment models. This was really where Sylvia Burwell was hoping to go. She wanted to encourage the development of models that did not depend on sort of fee-for-service kinds of billings. And one example of this is accountable care organizations. It's a complicated topic, but these are situations in which providers, doctors, hospitals, others join voluntarily to create this organization that's distinct from its parts, so that doctors are not the employees of hospitals here, but they engage with hospitals in these kinds of agreements to provide care to defined populations. And the good thing for doctors is that the doctors get favorable Medicare fee updates without doing the MIPS reporting if they participate in these alternative payment models. And at the ACO level, the ACOs stand to do well financially if they lower costs while hitting certain measurable quality targets. So they are able to share in the savings with Medicare. And the quality targets are things like blood pressure control hitting certain thresholds, cancer screening, and statin use rates hitting certain thresholds, depression screening hitting certain thresholds, and so forth. So these are national programs. But I would be remiss if I didn't mention something about what's been going on in Maryland specifically. I'll spend a couple minutes on this. Everybody, I'm sure, has heard of the all-payer system. This was originally introduced in 1977, and this is a system whereby all acute care hospitals' charges are set by a public agency called the HSCRC, Health Services Cost Review Commission, and they're the same regardless of payer. So there's no negotiating with payers about what the price of a day in the hospital is going to be, or what a colonoscopy is going to be cost. All payers are going to pay the same, but charges differ across hospitals. So hospitals don't all have the same cost, but a given procedure at a given hospital is the same regardless of payer. So this system was had added to it in something called total patient revenue. It's also called a global GBR, global budget revenue. This element was added on a pilot basis in 10 rural hospitals in 2010, then extended to all hospitals in 2014. And this is a system where Maryland hospitals have this guaranteed revenue base in terms of charges for a 12-month period, regardless of volume. So it doesn't matter how busy it is. It doesn't matter what the volume is. They can count on this revenue. And in return for this, Maryland agreed to certain Medicare savings targets, as well as certain quality goals, such as reducing readmissions and reducing hospital-acquired conditions. And the idea for Medicare, of course, is to reduce costs by reducing hospitalizations, and also to improve quality by reducing the frequency of certain undesirable outcomes, readmissions and the like. And then for hospitals, the idea is that they don't have to fret about volume. They have guaranteed revenue that can be used to improve services creatively. There's no incentive to maximize hospital volumes in the system, since increasing the number of services. In general, it doesn't increase revenue. There are exceptions to this, but in general, increasing number of services doesn't increase revenue. And it creates an incentive for hospitals to reduce costs, since lowering costs is really about the only way to increase margins. And you might lower costs by doing a better job of taking care of hospitalized patients, so there are fewer hospital complications that require expensive treatment and longer hospital stays and so forth. That's the intent here. So how have these different payment approaches worked? Well, first, on the national level with Medicare, the hospital value-based purchasing program seems to have resulted in some reduction in hospital-based conditions and readmissions. The cost impact has been somewhat equivocal, because the payment reductions, that 2% payment withhold, has been largely spent on incentives. So the cost impact has not been significant. And an unintended consequence, at least of that program, is that it may have exacerbated healthcare inequities. It's not surprisingly, the systems that were in the best position to earn incentive dollars were those that were best resourced in the first place. And the ones that were most likely to be penalized were those that were the least resourced, the safety net hospitals and those caring for the highest risk patients. How's it gone with the ACOs? It's a very complicated topic, but overall, there were some savings to Medicare on the order of 1 to 6% per capita. And there were, at least in some domains, superior clinical income. Some of the ACOs did better on some clinical indicators of clinical quality than other organizations and other kinds of providers. How's the Maryland program worked? Well, when it was reevaluated in 2019, after 5 years of this total patient revenue system, hospital revenue growth was lower than the percentage increase year over year was less than it was elsewhere in the country, resulting in significant Medicare savings on hospital care over that period of 5 years, about $916 million in Medicare savings on hospital care. The savings on total care, total cost of care were less than that, because more in the tune of 566 million. And that's because the cost, what Medicare spent on outpatient care went up, because some of what had been done in the hospital was now done on an outpatient basis, but still very substantial savings. And there was also a reduction in hospital acquired conditions, and the Medicare readmission rate was below the national average. So that was all counted as a success. And based on that, the model has continued. It's now called a total cost of care model. And the focus now is on what they call system-wide alignment, or bringing other providers, not just hospital providers, into the system. And one of the programs by which this is done is something called the Maryland Primary Care Program, which with which I think 500 some odd ambulatory practices around the state of Maryland are enrolled right now, including Hopkins outpatient programs. So what's the sort of interim verdict on value-based reimbursement? Maybe in a nutshell, well, certainly there's some evidence of cost reductions. As I said a moment ago, the ACO seem to have yielded some reduction in per capita costs for Medicare. And Maryland's system seems to have slowed cost growth. On the quality front, some improvements in hospital-based conditions readmissions in Maryland, some benefits of that hospital value-based purchasing system in terms of things like pneumonia-specific mortality, and better scores on some other process and outcome measures within the ACO program. But not surprisingly, the system has its critics, and the critics point out that things like the cost of the quality programs themselves haven't been figured into the total price tag here. That includes the cost of administrative activity to support measurement, that very elaborate system of measure development that I mentioned cost something. And in the 10-year period from 2008 to 18, CMS spent around $1.3 billion on measure development and maintenance. Health systems, foot a hefty bill, $3.5 to $12 million for measurement support, 50 to 100 employees for measurement support, and practices are been estimated to spend something like $40,000 annually to meet quality documentation requirements. So there are those dollar costs. And then there are the dollar costs of clinician time required to participate in the quality measurement programs. And their studies have shown that an average physician spends 2.5 hours a week on quality improvement documentation, and that clinicians, along with administrators, spend the equivalent of a tenth of an FTE per year meeting each physician's NIPS requirements. And there's more. There are problems for providers as well. There's been a lot written about burnout on the provider side due to the measure-related documentation requirements. There's been writing on what has been called moral injury due to focus on activities that clinicians recognize are there to support reimbursement rather than to meet the needs of the person sitting with them in the room. And of course, there's a risk of revenue loss due to not hitting the metrics targets. Then there are problems with the metrics themselves. Not surprisingly, when you're trying to do this kind of work at scale, you tend to measure what's easiest to measure, things that can be drawn out of the electronic record certainly fit that bill. And so what you're measuring isn't necessarily what's important or meaningful to those receiving care. And focus on these things, on these metrics, may divert attention and resources from activities that are more relevant and meaningful, but are not tied to reimbursement. So that brings us to this point here. So that with the focus on value today, we may lose sight of the fact that the quality isn't just a factor in this value discussion, which has understandably been made urgent by the cost issues. We've in healthcare have long been interested in assessing and improving the quality of care. So let's sort of take a step back and look at how we define quality before we were focused on value. And going to the dictionary, going to Webster, quality is the degree of excellence of something. And in some domains, it's simple, it's straightforward, it's, maybe one measure and uncontroversial. For those who follow such things, today is Patriots' Day in Massachusetts, the day of the running of the Boston Marathon. And this slide here shows last year's winners. In this domain, it's not hard to measure excellence. The measure is what the clock says when you cross the finish line, and it's a single dimension. But it's not so simple in healthcare. There's not a universal agreement, and it's not unidimensional. So what about quality in healthcare? So this slide here shows Avedis Donabedian, one of the spiritual fathers of quality assurance and quality improvement. And his components of quality in healthcare were these. There were 7 altogether: efficacy, effectiveness, efficiency. It's kind of clear what all those mean. Optimality, which I'd never really seen that word before, but this involves balancing of improvements in health against costs of such improvements, very much like the value idea. Accessibility, and what he referred to as the amenities of care. And then he also called out aspects of the patient-practitioner relationship as being key to quality, including attention to patient preferences, as well as honesty, truthfulness, concern, and empathy, and the like. So here's the list from the Institute of Medicine. There's 6 aims of high quality healthcare. I think many of you have seen these before: safety, effectiveness, timeliness, efficiency, equity, and patient-centeredness. And this involves providing care that's respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. And then there is the list in the Institute of Medicine's quality chasm document, where they list the 10 principles for the redesign of healthcare. And these are their principles: care based on continuous healing relationships, shared knowledge and free flow of information, evidence-based decision-making, safety, transparency, anticipating needs, not just reacting to needs, continuous decrease in waste, cooperation among clinicians, and customization based on patient needs and values, with the patient as the source of control. So here we have the opinions of think tanks, of experts, of scholars. Who gets to decide what constitutes good quality? Where does the patient fit into all of this? And Leah Binder, the CEO of the Leapfrog Group, which is a business group interested in healthcare, observed some time ago that in traditional value-based purchasing, excellence is decided by the health plan, the doctor, the federal government, some kind of political consensus. patient experience may have a vote, but individual patients don't decide for themselves. And ultimately, from a patient's point of view, the idea that anybody but you decides what defines acceptable care is disconcerting. So who decides how to define and measure quality, and does the patient have a vote? I think one of the most interesting perspectives on this comes not from a patient advocate, but from an economist, Michael Porter, who was known early in his career for what he wrote about competitive strategy, but he got interested in healthcare later on in his career. And this is what he thought. So he thought that value in general, whatever the industry, should always be defined around the customer. And he thought it should be the same in a well-functioning healthcare system. The creation of value for patients should determine the rewards for all the other actors in the system, the providers, the payers, everybody. And in the numerator of the value equation where quality was, he put health outcomes, and not just any health outcomes, but health outcomes achieved for patients. And he went on to create a model of sort of an outcomes hierarchy that has kind of a lot of appeal, and it has 3 tiers. One is health status achieved or retained, that includes things like outcomes like survival and the degree of health and recovery. This is sort of symptomatic improvement and measurable improvement in pathology. Tier 2 is a process of recovery, which is how long it took to get better, return to normal activities, and what the burdens of that were. And then tier 3 was the sustainability of health, that people, if they got better, stayed better. Now this, we don't have time to speak a lot more about this, but I think it has many strengths. It's comprehensive. It's focused on patient outcomes, but it has limits, and the limits have to do with the metrics that he was proposing be used in each of those tiers, were metrics that would apply to all patients. And of course, when you're talking about patients in this context, patient is an abstraction, it's not a person. And so his model doesn't really include any place for metrics that reflect the goals, values, and preferences of individual patients. And after all, every scheme that we looked at for defining quality had person-centeredness right in the heart of it. The IOM talked about providing care that's respectful and responsive to individual patient preferences, needs, and values. Donna Bedian talked about attention to patient preferences. The Quality Chasm document talked about customization on patient needs and values, and so forth. And so value to the person in the room is really part of each scheme, which brings us to this notion of person-centered care or personalized care. And why is everybody talking about it? Well, if you do a search on personalized care or person-centered care, all kinds of things pop up, all kinds of graphics and all kinds of content. But they have different kinds of perspectives on the notion. And I've found at least 4 different perspectives. One is as a frame for precision medicine, and we'll talk more about this in a little bit. Another is a marketing strategy. A third is as a model for practice and training. And a fourth is as a guiding principle for the transformation of healthcare systems pursuing value. So first, though, to marketing, at the top here, you see Penn personalized care. So the healthcare at Penn Medicine provides a personal approach to your health and wellness. NYU has the same sort of take on things, putting personalized care into practice. That's at the heart of the matter. Our friends up north at McLean characterize McLean as a place where experts who specialize in complex diagnoses create personalized treatment plans, and that's why you should choose McLean for healthcare. So it's all over people's marketing materials. Then there's the take on person-centered care as a model for clinical practice. And I think one interesting statement on this kind of approach to things came from Elizabeth McGlynn in a piece in the New England Journal back in 2014. She called Reimagining Quality Measurement. She was looking at quality in the context of quality measurement. And she observed that the quality measurement enterprise in the US is troubled, burdensome, expensive, inaccurate, misses what matters most to patients, doesn't deliver to patients information they need to make good decisions. So she was calling for reimagining quality measurement according to three principles: that it be integrated with healthcare delivery, that it should acknowledge real complexities of care, and it should reflect individual patients' preferences for treatment and health outcomes. So this is what she was proposing as the model here. Begins with a clinical assessment where a diagnosis is made and where the patient's unique clinical needs are identified. And then you would reference guidelines to identify good treatment options for the problems that the patient presented. And then you would go to the patient, determine what are the patient's goals and values and preferences, and you would base the choice of treatment, assuming there were choices, on goals, values, and preferences. And then you would focus treatment efforts on achieving these personalized patient-specific goals. And then if you were in the quality measurement business, you would judge the quality of care in terms of the achievement of those personalized goals. And another way of looking at a model of care with these kinds of characteristics was proposed by Glenn Elwin and his colleagues up at Dartmouth Hitchcock. There's a notion of co-production, and the co-production cycle as it relates to healthcare includes a step called co-assessment, where the patient and the clinician engage in this assessment of the patient's health status. They together decide on next steps based on the patient's goals. Together, they design a plan to fit the patient's goals and capabilities, taking into account the burdens of treatment. This is done collaboratively, and then co-deliver. So care involves a contribution from the patient, as well as, of course, a contribution from the professional clinical team. So this is co-production. In some ways, for me, the most interesting take on personalized care was as a guiding principle for healthcare systems pursuing value. The VA has apparently committed itself to this approach, and it calls it personalized healthcare and describes it as an approach to the practice of medicine where prediction, prevention, intense patient engagement, and shared healthcare decision-making are critical to cost-effectively providing care and getting the best outcomes. And they say that the VA is committed to incorporating a personalized healthcare into its delivery model. And what does this include? Prominent features include what they call dynamic customization of care that's specifically relevant to the individuals based on medical conditions, genome needs, values, and the like. And it's patient-driven, rooted in and driven by what matters most to people in their lives. It aligns with their day-to-day and long-term life goals. And they offer this graphic to describe how it's supposed to look. You've got the patient role in terms of personal health awareness and enhancement of that. They participate in a whole health self-assessment. You have the provider side where there's a health risk assessment involving the clinical exam and laboratory findings and the like. There's a determination of therapeutic needs. And then the patient and the provider come together in this shared goal-setting activity, leading to the creation of a personalized health plan. So this is how the VA is describing their approach to the sort of the transformation of their health system. And then perhaps even more ambitiously, you have the National Health Service talking about personalized healthcare as their operating model. And this is much too complex to go into in detail, and it's also operating in a different economy. But I found it very interesting that that top line in this model is shared decision-making and patient choice, in which people are supported to understand their care and the options and the risks and benefits. And they're part of making a decision about the preferred course of action based on their personal preferences. And also top line here, there's reference to people having proactive, personalized conversations which focuses on what matters to them most. And this approach involving shared decision-making and determining what matters most is seen as relevant at all places on the pyramid of the sort of epidemiological pyramid here. It applies not only to the whole population, but in one form or fashion, it's extended even to people with complex needs and people with long-term physical and mental health conditions. And anybody interested in this, if we had more time, I would show you a quick video of the description of this. It's fascinating to see how they talk about this as the direction they're taking to pursue value in the National Health Service. So what does it take to do person-centered care? Well, there are at least 3 prerequisites. You have to know the person with the illness. The person has to be a partner in decision-making, and their goals and preferences need to be taken into account in treatment planning. And of course, here at Hopkins, we know that there are different angles or perspectives on knowing the person. There's a biological or disease perspective on knowing the person. The disease perspective, of course, is all about understanding a syndrome as a result of disordered biology. And the more specifically we understand the biology of an individual patient, the better able we are to provide personalized biological treatments. This is, after all, the goal and promise of precision medicine. And I include this graphic I borrowed from Jimmy to show the precision medicine centers of excellence that we have here at Hopkins. But of course, there's also the life story perspective on knowing the person, because the experiences and traits and values, meanings that constitute the unique life stories of our patients have to be appreciated, understood if we're going to be able to provide personalized care. That's self-evident. And this was articulated, I think, in an interesting way by another Hopkins person, Roy Ziegelstein, who wrote about something he called personomics. He was recognizing that the tools of precision medicine include lots of omics, proteomics, pharmacogenomics, but that psychological, social, cultural, behavioral, and economic factors in each person are critical. And he proposed calling those personomics, and suggested those need to be part of, as we think about personalized care, we need to be giving personomics due attention, and this needs to be something all of our trainees are trained in. The second requirement is making the person a partner in decision-making. So this gets us to shared decision-making, this process by which patients and clinicians make decisions together. It involves a process of communication to which clinicians and patients work together to make optimal health decisions that align with what matters most to them. And it has 3 components. It involves good medical evidence about reasonable alternatives. It involves clinician expertise in talking to patients about these things in the context of their goals and values. This is the National Quality Forum description of the requirements of shared decision-making. And it's been studied a lot more in general medical settings, and some of the most interesting studies on this topic and other areas were summarized by an article by Zeke Emanuel up at Penn. He's an oncologist and a medical ethics guy, and one of the architects of the Affordable Care Act, who pulled data together that showed that with shared decision-making, patients are more informed, better understand the risks, and are more likely to receive care aligned with their values, and that they may tend to choose more conservative and less invasive care. And the result of that, as estimated by the Lewin Group, could be substantial cost savings. They estimated that shared decision-making for 11 procedures could yield $11 billion in savings over 10 years. And Group Health of Washington State actually found that when shared decision-making was offered with the assistance of what they call decision aids, and we'll talk about those in a second, with respect to hip and knee replacements, there were fewer surgeries and reduced costs. There's been less written about shared decision-making in mental health care, but SAMHSA, the Substance Abuse and Mental Health Services Administration, has promoted shared decision-making as an emerging best practice and identifies 4 elements to shared decision-making: establishing a partnership, exchanging information, weighing options, and making a decision. And these are the exchange of information, weighing options is facilitated by having what are called decision aids. And these can be written materials, they can be videos, they can be interactive web-based kinds of presentations that help patients understand the options and the risks and benefits of each. There's one on decisions called Decisions in Recovery for Opioid Use Disorders. They also have one on the role of on considering the role of antipsychotic meds. In recovery plans, there's a shorter module just on medication side effects. And there are lots of decision aids that are out there for healthcare in general on this healthwise.org website. Now, I'm just going to mention very quickly in passing that it's very complicated in mental health care to have this discussion about shared decision-making, because we worry about the ability of our patients, especially our most ill patients, to participate in this. And that complication is not lost on Ellen Sachs, who's an attorney, a professor of law at USC, and also a person living with schizophrenia. If you haven't heard of a book called The Center Cannot Hold: My Journey Through Madness, I'd recommend it to you as a riveting kind of first-person account of mental illness. And she fully appreciates that people don't always make decisions when they're acutely ill. She certainly didn't. But she still says the value of having autonomy and making one's choices can't be overstated. That's the reason that supported decision-making is so powerful. So instead of taking choice away from you and having the guard to make your decision, you get to make a decision with the support of others you trust. And the support of others you trust is a critical element of this. It's your decision in the end, though, and this idea of supported decision-making will restore more people to the role of architects in their own lives. So that was a bit of a digression, but I thought it was worth including. The National Quality Forum is very much behind the notion of shared decision-making and suggests that it be embraced and integrated into clinical practice as a standard of person-centered care. And since the National Quality Forum is all about measurement, it raises the question, is it possible to measure shared decision-making? And in fact, there are a couple dozen, at least, shared decision-making measurement methods, none in broad use, but there are a few. I mentioned 3 here. One is called the Shared Decision-Making Process 4, which is relevant to surgery. One I'm going to talk about just very briefly is called the Collaborate, a clever name, which is a 3-item measure that assesses the patient's perception of how much effort was put into including what matters most to them. And this is really what it looks like. Glenn Elwin up at Dartmouth Hitchcock, put it together, has been studying this. 3 questions that patients rate on a 10-point scale: how much effort was made to help you understand your health issues, how much effort was made to listen to the things that matter most to you about them, and how much effort was made to include what matters most to you in choosing what to do next. And patients, a self-rated scale that patients rate 1 to 10. I know at least one mental health setting in which it's used. A colleague who's in Arizona, Margie Balfour, who has up quality. She's a psychiatrist for a public agency, excuse me, and uses this in her suite of measures. So finally, the 3rd prerequisite is taking the goals and preferences of our patients into account in treatment planning. And this is not a new idea. It's those of us who work in inpatient units know about having to create goals of treatment. It's mandated by accreditation standard and regulations in lots of treatment settings. And it's the subject of formal research as a way to guide and evaluate psychotherapy. And when I looked into this, I found that one of the first entries was actually a Hopkins entry. There was a study called Target Complaints as Criteria for Improvement, published in the American Journal of Psychotherapy in 1966, and Jerome Frank was a senior author. And the idea here is you look at patients' complaint and their rating of how much progress they made in dealing with the problem they came up with, and that would be the criteria by which improvement would be judged. Well, you can see the appeal of this on an intuitive basis. If you have agreed upon goals, it reduces the risks that the patient's goals and the efforts of the therapist are misaligned. It helps the patients and therapists focus on what matters most to patients, and empowers patients who might be demoralized by treating them as people who have the potential to have impact on their lives. Now, is it possible to measure and track personalized goal achievement? Well, in fact, there's a literature on this, on using goal-based outcomes in therapy. And Duncan Law has done a lot of writing about this. And the model involves identifying potential goals, and then working with the patient to shape them into goals that are acceptable to the patient and the clinician, writing them down on a goal-based outcomes record sheet, rating the level of achievement at the outset of treatment. Where does the patient stand in terms of achieving that goal at the time that treatment begins, and then rating progress periodically over the course of therapy. And here are some forms that they put together. This is a form for writing down the selected goals. This is a form for rating where the patient believes he or she stands in terms of reaching that goal at the beginning of treatment. And then there's a form for where the patient would rate how closely they've come to meeting a particular goal over the course of the treatment. Maybe in session 1, they would rate themselves at a 2. Maybe by session 6, they'd be at a 6 if things go well. Maybe by session 10, they rate themselves a 9. Has this been used? It has been used in research settings, and when it's been used in research settings, self-rated progress in achieving goals using these kinds of goal-focused measures has been more sensitive to change and has picked up improvements in areas that the patients were most interested in better than standard measures that were not really tied to their goals. There are other self-report instruments out there that follow a similar kinds of model. They're mainly used as a guide to treatment, but there's also been discussion of using them as a population indicator of outcomes, along with other established standard scales. You know, my slides are not advancing. I apologize. Okay, there we go. Okay, so where does that leave us here? And by way of conclusion here, and with some aspirations in terms of where we might go here. How can we build on these ideas here? Well, I think we have the potential. We have compatible clinical programs. I think we have lots of programs, in fact, where goals are set in collaboration with patients. I work in the community psychiatry program here at Hopkins, and I can say that personalized goals are developed for every patient. They're documented in a standard note, and progress is formally assessed qualitatively with the patient at prescribed intervals. So we've got, and I know there are other programs that do this as well here. And then we have measurement-based care that is being deployed gradually system-wide, and this is Peter Zandi's My Care program, which clinical programs have the option of selecting from a menu of validated patient-reported outcome measures. They complete these measures electronically at baseline and at certain selected milestone points, and the data are available to clinicians to aid care. So my question to us as a community here is, do we have an opportunity to combine measures of person-centeredness, things like the Collaborate or maybe goal-based outcome measurements, with familiar standardized measures such as the PHQ-9 and the like, to enrich our approach to measurement-based care? This could serve as a form of valuable feedback to providers and to patients about how care is progressing. And of course, to minimize the burden, we need to be incorporating these into workflows, and they have to be self-administered by patients and be readily available to providers at the point of care. All right, so we've covered a lot of ground here. Let me just summarize very quickly. We've talked about the value movement and seeing that it's driven by cost, primarily honestly cost, but also quality concerns. We've looked at value-based payment to date. We've seen that it's resulted in some cost reduction and some quality benefits, at least in some settings. We've also seen that it has problems. They're unaccounted for dollar costs. There's provider demoralization. There are problematic metrics. We've seen that our interest in quality predates today's focus on value. We've seen that patient-centeredness, or really person-centeredness, is a core element of quality. We've seen that it's possible to measure aspects of person-centeredness, and I think we've seen that person-centeredness is really kind of emerging as the holy grail of healthcare in many domains, in biology, in the guise of precision medicine, but also in clinical care, marketing, and even systems redesign. So how does person-centeredness and high-value care, how do they reconcile? How can they be reconciled with each other? How compatible are they with each other? Well, I think it could be argued that person-centeredness might be the path to high-value care that best reconciles the interests of all value-interested parties, the payers, the providers, and the person in the room. And I'll let Don Berwick have the last word here. Don Berwick was a Medicare administrator for a number of years, is also a big name in healthcare improvement, and one of the founders of the Institute for Healthcare Improvement, who wrote that the overarching of ideal medical practice is giving patients the help they need and want exactly when they need and want it. And at the centerpiece of all this is what he calls patient-centeredness, which is really person-centeredness, the experience of transparency, individualization, recognition, respect, dignity, and choice in all matters without exception. It's that property of care that welcomes me to assert my humanity and individuality. And if we be healers, then I suggest this is not the root to the point, it is the point. And with that, I thank you very much.
Terrific, Bob. Thanks. Really interesting overview of an awfully important issue. You know, I think it's always seemed to me one of the big problems with metrics is that invariably they are this very extremely blunt instrument that comes down from a centralized source and is meant to apply to an enormous range of situations, and it very imperfectly applies to so many of those situations. And conversely, the ideal of the patient-centered approach would be that each individual has extremely individualized set of goals, which would be, 180 degrees different from this monolithic approach. And I guess I wonder, I sort of imagine that the ideal measurement might be in some sweet spot, something like halfway between those two, where you have a range of potential measures that you pick for a given patient. And that's a bit like what MyCare, I think, is doing, if I understand it correctly. MyCare has a set of measures being applied to people, and in any given clinic, they pick particular ones. I don't know, do you think that in between ground is the way to go?
No, I think it is. I think the ideal suite of measures would include those standard measures that seem most relevant to the population, but I think they may also include some of these other measures. And it's interesting to me that these big agencies, the National Quality Forum, has been interested in incorporating this kind of measurement, and even the NCQA, the National Committee on Quality Assurance, which is this entity that creates measures for health plans, is interested in figuring out a way to include this sort of person-specific kinds of measures in their suite of measures. So I think some combination of sort of standardized measures along with these more person-centered metrics would be the best way to go.
Mm-hmm. Mm-hmm. Thanks. Pat Triplet says, thanks, this is great. Building on Jimmy's question, is there a role for a more inductive, less top-down approach to personalized care, starting with smaller populations and focused conditions? I'm reminded of some of the work our geriatric day hospital did with late-age depression.
Right. I think that you can approach this by being much more granular in terms of the approach with a group of patients. That's not quite as demanding as being patient specific, but it's much more likely to yield information about the quality of care that's being provided to a particular group. But I think the idea, the kind of radical idea here is being more person specific, and to see the VA and the National Health Service in the UK as advocating for sort of goal setting and assessment of quality at this kind of granular level is very interesting, and suggests that we might be able to be more ambitious about how we approach this.
Great. And Ray DePaulo says, Bob, I'm concerned about the lack of the simple concrete monitoring of the changes that flow from the incentives and then acting to improve them over time. The most obvious is the incentive system that mandated EMRs and led to the Epic system dominating the medical marketplace, despite its obvious structural flaws. It's the cost to patients and clinicians in terms of time and morale is well documented. It seems that nothing is being done to fix or replace it. Why not?
And I think that's a universal lament. I honestly don't know what the answer is. It's so embedded in how we think these days. In fact, I spoke to the folks who over at the Armstrong Institute who manage the merit-based incentive system measurements for Hopkins, and it's entirely Epic dependent. So we wouldn't be able to function in this world of measurement-based care, without systems like Epic. At this point, it's really worked its way into our processes.
Sorry. So one more, we have time for one more question, and that will be from Russ Margolis. Drug A is 10% better for patient than drug B and is preferred by the patient, but drug A is 50% more expensive and both will be paid for by the payer. How does value-centered care versus person-centered care reconcile this?
Mm-hmm. Well, I think there's a value judgment there, I guess. And there was an example in one of the articles written about this by Lisa Rosenbaum, who talked about a surgeon making a decision to do an operation, even though it was an expensive measure, because it was important to the patient to have the operation, even though his judgment was that it wasn't going to yield all that much. And he went ahead and did the operation because he thought that was the right thing to do. So I think it comes down to a value judgment and maybe who's making the decision about what matters more.
Okay, well, one more question snuck in. And so from Geeta, thanks for focusing on quality of care. In the 80s and 90s, we worked on health services research with Steinwachs and noted that measuring quality with active components of care, such as reducing use of seclusion or restraints and preventing self-harm, did not earn us extra dollars. How can we be paid more for better quality care?
Mm-hmm. Well, I think that's where we need to be lobbying the payers, and I think that's where patients need to be lobbying the payers as well. I mean, I think patient engagement in this is critical, and I think the voices of the consumers, the patients, is sometimes more important to the payers than the voice of us as providers.
Good point. Good point. Well, thanks, Bob. Very, very interesting. Thanks, everybody, for tuning in, and have a good week, folks.
Thank you all.